Hello, I'm Dr. Yvette Rubidoux, and I'm the Director of the Policy Research Center at the National Congress of American Indians. Welcome to our monthly webinar series. Today, we will focus on neonatal opioid withdrawal syndrome in American Indians and Alaska Natives. This webinar topic was requested by our tribal partners with the Collaborative Research Center for American Indian Health in Sioux Falls, South Dakota. So thank you to you if you are listening. Our last webinar was in April, and the topic was an overview of dissemination and implementation research. We took a break in May and June, and now we'll start again with our monthly webinar series. And if you've missed any of our webinars, the recordings are available on our NCAI YouTube page or on our website, www.ncai.org/PRC, under Events and Webinars. We're so glad you joined us today, and we encourage you to watch for our monthly webinars, usually on the fourth Thursday of the month, that will focus on how data informs policy, and will feature a variety of topics and various guest speakers from time to time. I encourage you to join our listserv for announcements by emailing research@ncai.org. Here's an overview of today's agenda. I just provided a welcome, and our speaker is Captain Ted Hall, who is the Ho-Chunk Nation Director of Pharmacy, Chief Pharmacist, and the co-chair of the Perinatal Substance Use Workgroup of the Indian Health Service Heroin, Opioids, and Pain Efforts Hope Committee. And we will reserve time for questions at the end. But before we get started, I'm going to review a few housekeeping items and let you know how you can participate in today's web event. So this is a depiction of the GoToWebinar Attendee Interface, and it's made up of two parts: the viewer window on the left, which displays the presentations, and the control panel on the right. I'll quickly navigate how to use the control panel so you can readily participate in today's web event. By clicking the orange arrow, you can open and close the control panel. And here's where you'll find all of the information about your audio connection. We recommend dialing in via phone rather than the computer, as it tends to limit feedback. To dial in, you will find the number and access code here, along with your unique audio PIN. As you can see, all attendees are currently muted and in listen-only mode. At the end of the presentation, we will open for questions and answers. At this time, please submit your questions via the questions pane. As a reminder, today's webinar is being recorded. After the event, you will receive an email with a link to a short evaluation, as well as the recording, which will also be available on our NCAI YouTube page and our PRC website. And now I'm happy to introduce our speaker today, Captain Ted Hall. Go ahead, Captain.
Thank you, Dr. Rubidoux. Good afternoon, everybody. Aho, Hamte E, Hija Kishna Hini Karagiwi. That's today. Hello, I greet each and every one of you. And I want to thank you for the opportunity to be able to talk to you today about some updates on neonatal opioid withdrawal syndrome in American Indians and Alaska Natives. So before I start, I just want to give a background of the Heroin, Opioids, and Pain Efforts Committee. It started out in 2011 from the National Indian Health Service National Combined Councils as the Prescription Drug Abuse Workgroup. That workgroup had done a lot of work with developing public domain websites for pain management and then opioid dependence management. And then in 2017, we became chartered as Heroin, Opioids, and Pain Efforts under the Office of Clinical and Preventative Services. So one of the sub-work groups that I co-chair is the Perinatal Substance Use Workgroup. So we've been doing a lot of work and are continuing to do a lot of work. So we'll be showcasing some of our upcoming releases that will be helpful resources for your clinicians and your tribal health programs and communities. Next slide, please. So the disclaimer is that the material presented today are the opinions and conclusions expressed of myself and don't necessarily represent the views of the U.S. Department of Health and Human Services, U.S. Public Health Service, Indian Health Service, or Ho-Chunk Nation. And I have no relevant financial or non-financial relationships to disclose. Next slide, please. So to start off with some general definitions. So you're going to see NAS versus NOWS. So neonatal abstinence syndrome, according to the American Academy of Pediatrics, is a clinical diagnosis, and it's also a consequence of the abrupt discontinuation of chronic fetal exposure to substances that were used or abused by the mother during pregnancy. So that can include not only illicit substances, but also prescribed medications, pain medications for pain syndromes, anti-anxiety medications such as benzodiazepines, or even anti-epileptic or anti-seizure medications that mom has used. So whenever there's an abrupt discontinuation of a chemical, it's going to have some consequences on the developing fetus. A new emerging term that we're going to see is Neonatal Opioid Withdrawal Syndrome, NOWS. So it's NAS, but it's very specific to opioids. And opioids include a broad description of substances that include prescription medications that you may be familiar with, such as hydrocodone or Vicodin, oxycodone or Percocet, buprenorphine products such as Suboxone or Subutex, methadone, all are prescribed medications, and then we have our illicit opioids such as heroin or carfentanil. Next slide, please. So some recent data and trends. I've looked at the most current information that I was able to find came out of the Center for Disease Control on their mortality or their morbidity and mortality weekly report in August 2016. And we can see that there was a 300% increase between 1999 and 2013. So if you look at that picture, you can see some alarming statistics. Every 25 minutes, a baby is born suffering from opioid withdrawal. You can see some financial implications of the cost of hospital stays. I would imagine that the trends are actually much higher in some of our tribal communities. Sometimes collecting data and sharing data have some unique challenges, as well as we can probably extrapolate that the rates are probably much higher even in today at 2018, as this data is a little bit antiquated. So we know that we have a problem, and we share that problem with the general community, although our tribal communities have some unique challenges in themselves. Next slide, please. So whenever we identify a problem, and this is a big public health problem that's affecting not only our communities, but our future generations, we want to look to solutions and not just be problem focused. So I wanted to just discuss some new guidelines that are about to be approved and released. And I apologize that I don't have an actual release date, but these are two guidelines that have been worked on for quite a long time with some important partners like the Indian Health Service, the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics Committee on Native American Child Health, CONACH, and the Office of Women's Health, as well as the American Academy of Pediatrics. They're two distinct guidelines, however, they are going to cross-reference each other because this is going to reflect both the mother and then also the baby after being born. So the first guideline is the American College of Obstetricians and Gynecologists, Recommendations to the Indian Health Service on Standards of Care for American Indians and Alaska Natives, Pregnant Women, and women of childbearing age with opioid use disorder. So the goal of this guideline is the management of substance use disorders, especially opioids, among Alaskan Indian and Alaskan Native American Indian and Alaska Native women and nows and their newborns. The second guideline is Indian Health Service Best Practice Guidelines Neonatal Opioid Withdrawal Syndrome, which is the best practices surrounding screening, diagnosing, and treating mothers and infants affected by prenatal opioid exposure. We had a meeting in the last couple of weeks that we're hoping that is going to get through Health and Human Services approval and release sometime late summer, so mid-August to early fall. It was consensus among all of the team members that this information is too critical and pertinent to delay any kind of release, so they're moving forward through their final approvals. Being that we're partnered with some external partners, they had to go through their own internal approval processes, but we're in the final stages, and we're going to, later on in this presentation, I'll let you know where these guidelines will be able to be retrieved once they're released. Next slide, please. So in these guidelines, as well as some existing guidelines, I'm going to highlight some of our key concepts. I think the most important key concept to consider throughout all of the different issues and around this is to maintain the integrity of the mother-child dyad. It's the most essential component. So substance use disorder does not always translate to child neglect. And I know that sometimes this is a difficult concept, and it has some controversy around it, but there are instances where a mom may have a diagnosis of substance use disorder, which is actually a primary medical condition. It's a complicated biopsychosocial chronic condition of the brain that requires treatment very similar to other conditions like hypertension or diabetes. And it does, like I said, does not translate to child neglect in all instances. So if mom is being treated adequately with medication therapy, counseling, and they're following up with their child visits, their child health visits, that's not necessarily neglect. Now, however, if a mom has a substance use disorder and is not following through with their prenatal care, care for herself or the baby, then that's where social services can come in and assess whether it is actually child neglect or not. So it does require multifaceted treatment, so appropriate medically assisted treatment for opioid disorder. We have a new emerging language around this called opioid use disorder pharmacotherapy that will be replacing medically assisted treatment. And we'll see that in the SAMHSA, Substance and Abuse and Mental Health Service Administration, tip number 63. Trying to understand the language to minimize stigma. Stigma is also another word that is going to be sunsetted and not appropriate to use when discussing substance use disorders. That's reflected in that SAMHSA tip 63. Stigma is going to actually be replaced with the word discrimination. We want to make sure we're not discriminating against our patients that have substance use disorders when we're providing them opportunities for treatment. So it's important for medically assisted treatment to prevent pregnancy complications, encourage prenatal care, reduce criminal activity, and avoid risks to the mother associating with the drug culture. So some examples of this that have come out of literature from the American College of Obstetricians and Gynecologists is that the fetal effects of continued heroin use include fetal growth restriction, abrupto placentae, which means placental abruption. So the placenta detaches from the uterus, and then the fetus is no longer viable. Fetal death, preterm labor, and intrauterine passage of the meconium. So some of the lifestyle effects that are associated with the drug culture are hazardous activities to support addiction, such as prostitution, theft, and violence, or potential exposure to dangerous situations from like sexually transmitted infections. They're often victims of crime. And there's also legal consequences that can lead to loss of child custody, criminal proceedings, and incarcerations. So all of these deleterious effects point to the importance of ensuring that we're encouraging and supporting our mothers to seek out treatment and to understand from a healthcare perspective, from a law enforcement perspective, and from a strengthen our community perspective that we should be placing as many opportunities to seek out and receive treatment for our mother-child dyad as possible. So, some maternal history risk factors that some of our healthcare providers are able to help identify some of our mothers are a known history of opioid use, abuse in current pregnancy, use of prescription medications for pain control, late or no prenatal care, and unexpected complications of the pregnancy known to be associated with drug use, including unexplained late fetus demise, precipitous labor, placental abruption, and preterm labor. So again, just the concept of encouraging our individuals, our pregnant moms, to seek out services in the health clinic without feeling that they're going to have any kind of punishment or repercussions for presenting and possibly having a substance use disorder. So collaborative management of co-occurring substance use disorders is essential, and that's including collaboration and coordination with mental health disorder and substance use counselors. So we have to have a personalization and acknowledging intergenerational and personal trauma. Oftentimes, individuals that have substance use disorders are self-treating for an underlying mental health condition or some sort of trauma. It's important to have this collaboration for the newborn and family care, as well as encompassing the extended family to help them understand some of the complications that come along with neonatal opioid withdrawal syndrome and the importance of support. Next slide, please. So for the incarceration, strategies can cause potential harm to mother and fetus, as I alluded to in the prior slide. According to the ACOG, opioid detoxification during any phase of pregnancy is contraindicated due to the high risk of spontaneous abortion, which translates to unintended loss of the baby, resulting from the traumatic physiological stress of opioid withdrawal to the pregnant mother and developing fetus. Opioid withdrawal is such a traumatic physiological event that it places baby at harm at any phase of development, even after conception, immediately after conception. So that points back to the importance of continuity of care with their medications. Legislation often criminalizing substance use disorders in pregnancy can contribute to unintended consequences and risks to the developing baby. So separation of parents and children solely on the basis of diagnosis of substance use disorder should be strongly discouraged. And I have the reference listed there below if anyone is interested in further reading about that. I know oftentimes it's difficult to accept that we're going to continue substance use disorder and maintaining that with buprenorphine products, which is an opioid that is indicated for opioid use disorder, and it's indicated in pregnant moms as it's a safe modality to prevent the event of opioid withdrawal. It will lead to neonatal opioid withdrawal syndrome, where the baby will have withdrawal syndrome upon birth, but again, that doesn't always translate to neglect. It's actually a medical condition. Next slide, please. So medication-assisted treatment is a standard of care, and discontinuation of opioid in pregnancy is extremely dangerous to the fetus, and under no circumstances is it advised. So oftentimes if a mom is arrested and incarcerated, it can lead to separation from their medications and create a withdrawal syndrome in the jail setting. So we have to be very cognizant about that, and especially in the way that we're strategizing our community policies and tribal law. So an important concept also to be able to distinguish between screening and the treatment versus legal action. So screening for substance use disorder is a standard component of obstetric care. There are two main evidence-based tools. One is called the 4 Ps. And the reason why it's called the 4 Ps is because the P stand for parents. And the question is, did any of your parents have a problem with alcohol or drug abuse? The second P is partner. Does your partner have a problem with alcohol or drug use? The third P is past. In the past, have you had difficulties in your life because of alcohol or other drugs, including prescription medications? And the last P is present. In the past month, have you drunk alcohol or used other drugs? And on that scoring, if there's a yes to any one of those 4 questions, then it's going to cause the healthcare provider to discuss treatment options and to seek further screening to find out what services may need to be offered around that individual. The second tool that is often used is called CAPT. The C stands for car. Have you ever ridden a car driven by someone, including yourself, who was high or been using alcohol or drugs? R is, do you ever use alcohol or drugs to relax? That's the R. Feel better about yourself or fit in? The A is for alone. Do you ever use alcohol or drugs while you are by yourself or alone? The F is, do you forget things you did when using alcohol or drugs? The next F is, do your family or friends ever tell you that you should cut down on your drinking or drug use? And then the T is trouble. Have you ever gotten in trouble while using alcohol or drugs? And again, 2 or more positive items indicate the need for further assessment and treatment. So when we talk about screening, we have to distinguish between the screening tools that I just discussed and biological testing, which is blood or urine collection, that do require informed consent and that absolutely should be obtained prior to collecting blood or urine. And that has been established through legal precedent and professional guidelines, again, in the mindset of trying to protect the developing baby and the mom and trying to ensure that we continue the integrity of that mother-child dyad. So screening should be used for the purpose of medical decision-making, treatment, planning, and referring to appropriate services only. It should be discouraged for punitive actions. Next slide, please. So with proposed solutions, here are some opportunities that are for interventions, and these are going to be some of the main solutions that are going to be outlined in the soon-to-be-released ACOG recommendations to the IHS guideline. So SAMHSA has a evidence-based tool called SBIRT, Screening, Brief Intervention, and Referral to Treatment. This is deployed in the primary care setting, so a physician or a nurse or a pharmacist can deploy this, where there's a brief screening with a screening tool around substance use disorder, and then a brief intervention, which can just be a discussion about what kind of resources are available or some potential consequences of continued substance use without treatment to mom and baby. And then referral to the appropriate services, such as behavioral health or social services for support. Prevention of opioid use disorder and opioid overdose. So we have our naloxone strategies around prevention of overdose. Encouraging and really emphasizing prenatal care for women with opioid disorder. We know that we have better outcomes when moms are continually engaging in their prenatal care and getting all of the support necessary. Behavioral health and substance use disorder counseling is an essential part in combination with the medication therapy to help them with improving their psychosocial strategies around coping with life. Medically assisted treatment, the two that are approved are methadone and buprenorphine, And buprenorphine is the office-based treatment that can be deployed in primary care settings until postpartum. And then after postpartum, there can be discussions about tapering buprenorphine to a naloxone product, which is an opioid antagonist, because then mom can safely withdraw after a baby has been born. Postpartum care is also important in neonatal opioid withdrawal syndrome because some of our babies that are born with neonatal opioid withdrawal syndrome require some extra attention and care that are unique. So in addition to possible medication management after birth, such as a morphine or methadone drip, to help minimize the fetal opioid withdrawal, there are some non-pharmacological or non-medication interventions that are very important. Some supportive care strategies include swaddling, which means tightly wrapping the baby in the blanket, as much skin-to-skin with parent as possible, rocking, rooming in, which means the baby is in the same room with mom at all times after birth and even after being discharged from the hospital and sent home. Minimal sensory or environmental stimulation. So we want to have calm environments that are dimly lit. Sometimes these neonatal opioid withdrawal syndrome babies are easily hyper-aroused to noises, so we want to keep it a calm setting. Maintain temperature stability. Providing baby with a pacifier for non-nutritive suckling. And then breast milk feedings are extremely important, and that may reduce the need for pharmacological intervention. If mom is being treated with buprenorphine for substance use disorder, some of that will transfer into the breast milk, and that will help the baby as the breastfeeding to not need additional medications. So also, babies who are withdrawing may have significantly elevated needs for their caloric intake. So sometimes they might need some additional supplemental formula in addition to mom's milk. And then also possibly talking about long-acting reversible contraception while mom has substance use disorder, just to prevent future or unintended pregnancies and complications. But that's all going to be dependent on and keeping in mind mom's autonomy and rights, whether that is going to be part of the family planning that they are open to discussion for and accepting of. Next slide, please. So before we get to questions and discussions, I also wanted to discuss that we have some available resources at the moment on ihs.gov/ODM, or if you're on the IHS website, if you search for opioid dependence management, we have a maternal child health webpage that has our existing NOWS guidelines that will help with medical providers, both in primary care and hospital settings, for the management of babies that are born dependent. And there's no standard in any kind of medication dosing for babies who are suffering from NOWS in the hospital, but there are some great examples that we have cited in the guidelines that are on the webpage at the moment. And the guidelines do refer back to a lot of these concepts in much more detail, as well as there's a lot of other resources from ACOG and other guiding documents that are housed on that website at the moment. But that's only going to be available until July 23rd. After July 23rd, both the opioid dependent management and the pain management websites are going to be combined into ihs.gov/opioids. And that website is going to house pain management, child maternal health, medically assisted treatment, as well as opioid overdose prevention guidelines and information. And those are going to be updated through the HOPE committee on a routine basis. And this is the website where these two guidelines that I referred to will be housed as soon as they're released. So with all of that information, I'm very looking forward to questions and comments. So Pinagigi, thank you for taking your time to listen to this information today.
Great. Thank you so much, Captain Hall. That was really useful and interesting information. We really appreciate the update. And now we'll take time to ask some of the questions that the attendees have submitted through the questions pane. And for the attendees, you can continue to submit questions on the questions pane, and we'll try to get to as many of them as possible before the end of the webinar. I noticed a couple of people thought that the slides weren't being advanced at some point, but it probably was the internet connection. We have another computer here, and it was advancing. So I would suggest if you're still having problems with the slides, send me a question, and the video will have all of the slides in it if you didn't get a chance to see that. So I apologize about that. So our first question is, do causes of neonatal abstinence syndrome also include ethanol and/or nicotine?
Yes, that's an excellent question, because as I said earlier, that any kind of chemical exposure to the developing fetus can have some deleterious or negative consequences. So there is another syndrome that's called fetal alcohol syndrome that has its own clinical course for individuals who continue to use alcohol during pregnancy. And that has a whole nother set of complications and treatment uniqueness to that. As well as with nicotine, we know that recreational use of nicotine, not necessarily ceremonial for traditional purposes, but continuous use for recreation, does also have consequences on the baby's health with the size and general health after birth. So again, those neonatal abstinence syndrome does include those substances as well. And that's why early on I wanted to distinguish the difference between neonatal abstinence syndrome, which is a much broader term, than neonatal opioid withdrawal syndrome, that really we're focusing on the consequences of opioid use during pregnancy.
Great, thank you very much. The next question is, we really need IHS-specific data to fully understand this issue. A recent county-level publication of chronic opioid use and abuse did not correspond very well to reservation boundaries.
I absolutely agree with that comment. And our HOPE committee, in particular, the work group that I'm co-leading with Dr. Jonathan Gilbert, we are looking at ways to better collect data from our tribal communities and that are more reflective of the unique challenges and the trends that we're seeing, and use that information to better strategize our solutions towards it. Because agreed, we can't, even though the only data we have is from county and state, and we can extrapolate some treatment guidelines from there, we definitely need to look at our tribal communities. And one thing that often gets missed is the resiliency and some of the protective factors that our tribal community displays and demonstrates in substance use disorder. So incorporating a lot of our traditions also are very protective in incorporating community as a protective factor against substance use disorder, both in the treatment, prevention, and then long-term recovery in individuals who may have struggled with it. So thank you for that comment. I'm definitely bringing this back to our work group and making sure we emphasize on how we can overcome our barriers and challenges to collecting that tribal data.
Thank you for that. I was at a couple of conferences recently, and I overheard some tribal epidemiology center people and some local people talking about how hard it is for them to get data on their problems with opioid abuse in their communities, and are there ways that they can use the IHS RPMS data to get information? And it sounds like that's pretty difficult as well.
I think one of the challenges is not so much the data collection, and so again, referring back to the 4 Ps and the craft, in our work group, we're working on how to making that a standard in all RPMS as a template to make sure that that screening is being done and that the information is being collected. I think some of the challenges really surround the release of that information from the tribe, depending on where it's being collected, whether it's IHS or an area office. So we understand that sometimes that data sharing requires extra like memorandums of agreement or internal IRB releases. So some of the challenges come from even the individual tribes wanting to release that information, and there's a lot of reasons for that which are very valid, and I can understand why. So sometimes we may not want to recognize that maybe like how do we fare versus other tribes, are we better or worse, and is there going to be a judgment around that? So as well as some inherent distrust again that relate back to historical trauma. So again, some of those barriers we're trying to look at and overcome through education and awareness that the information and data is going to be helpful and useful in trying to develop unique strategies for each individual tribal community.
Great, thank you. The next question is, having been a foster care provider for newborns for over 20 years, the last 10 years having only neonatal abstinence babies, my experience with the babies is that not all newborns like to be swaddled. Each newborn has their own sensory issues. It is unfair to state a generalization in caring for our future generations. Any comment to that comment?
Yes, absolutely. Thank you so much for that comment, and I agree as well. So when we talk about neonatal abstinence syndrome babies, again, depending on what the substance was that was abused or misused during pregnancy, an individual a baby who is suffering from a benzodiazepine withdrawal versus a baby who is suffering from an opioid withdrawal from prescription drugs versus a baby who is withdrawing from heroin are all going to look very different. And I agree, it's very dangerous to apply generalizations because every baby is going to be unique in their sensory needs, and swaddling may actually be stressful if the baby doesn't require it. So again, with that universal recommendation, there's going to be a disclaimer of course to adapt it to that baby's unique needs. I think why they're having that for neonatal opioid withdrawal as a universal recommendation is because I think over time in a lot of healthcare systems that they've seen that babies wind up needing a little bit more closeness and connection. But again, I understand and respect your comment that that's not the case for every single baby. And thank you very much for all of the wonderful work that you've done over the past 10 years, given these babies who might be struggling with neonatal abstinence syndrome, that special care that they need.
Great, thank you. The next question is, how do you identify neonatal abstinence syndrome from other substances that may have been ingested during pregnancy?
So that question, probably the way to distinguish is we're going to need some objective data, meaning we're going to need to have urine drug screens throughout pregnancy, again with mom's consent, and for the purposes of understanding what medications might be on board during pregnancy. And again, some may be prescribed and some may be illicit, and not from a punitive perspective, but to understand the differences of how those medications are going to create different needs upon birth. So a very good history from a mom, a pregnant mom who trusts their healthcare provider to be open, honest. So I would answer that with very good histories of presenting illness and getting good information from mom, as well as some objective information through, oh, sorry about that, that's my timer. Making sure that we get some objective data to find out what's in the bloodstream so that we can better predict and treat with babies. So not every single baby is going to require medication management upon birth. So that's all going to be determined as the baby is born, and there's something called a Finnegan scale, which is done in the hospital by the healthcare staff, and that is a questionnaire that's administered through clinical observation of the baby by a trained healthcare professional like a nurse or an obstetrician. So based on the Finnegan score, that usually determines whether a baby is going to need medically assisted treatment to withdrawal, such as a morphine drip and a taper over a couple of days. I hope that answers that question, but let me know if it didn't fully answer your question.
All right, thank you. The next question is, can you go into more depth how culture and identity will play a part in your proposed solutions? What is specifically affecting Native peoples?
Absolutely. So this goes out beyond neonatal abstinence syndrome to substance use disorder, which actually what I do on a day-to-day basis. I'm actually a board-certified psychiatric pharmacist, and I have prescriptive and diagnostic authority for substance use disorders and mental health conditions. So I actually run a medically assisted treatment program using naltrexone or Vivitrol, which is an opiate antagonist. It blocks opiate receptors. Underneath, I'd say about over 90% of my patient population has an underlying mental health or trauma that they've been self-treating for a very long time with drugs and alcohol. So to get a better understanding of neonatal opioid withdrawal syndrome, neonatal abstinence syndrome, going back to mom's initial reason for use, was it recreational and just for euphoria? Or was it truly because they had experienced some kind of childhood trauma, or they're dealing with some kind of life stressor that is so difficult to cope with that unfortunately drugs and alcohol are their primary coping mechanism? 100% of my patients who are receiving Vivitrol must be engaging in mental health and alcohol and other drugs of abuse counseling, because we know that we have historical trauma, intergenerational trauma, and immediate trauma in our communities, but then each individual in the community is going to have their own unique risk factors or causes for using drugs and alcohol as their use for self-treatment. So what are our strategies around that? We're going to definitely encourage evidence-based programs like community awareness about substance use disorder as a chronic disorder similar to diabetes, to normalize it out that it's a medical condition and not just the stigma of a bad person doing bad things, as well as communities that haven't performed a GONA to get a better understanding of the unique contributing factors in their own community, and to really reinforce each individual tribe's culture and traditions and incorporate that into the treatment and prevention of substance use disorder by fortifying culture through like language and other unique traditions to that individual tribe.
All right, thank you. The next question is, my first neonatal abstinence syndrome baby was in 2006. What federal legislation is currently being introduced that works with all the federal and state branches of government to combat the opioid epidemic?
So one of the most recent legislation is the CARA Act. So that's of 2000, I believe it was 2007. So what the CARE Act did was it expanded the use of naloxone to be able to be obtained at local pharmacies without a prescription. Getting naloxone, which is opioid overdose prevention, as well as allowing the data-waived providers to have increased patient loads. So historically, or from in the past, only physicians and so MDs and DOs were able to get the special training and the data waiver X license from the DEA to prescribe buprenorphine. So then from the CARE Act, what that allowed was mid-level providers such as nurse practitioners and physician's assistants to also prescribe buprenorphine. And previously, the data waiver only allowed 100 active patients per physician. With the new CARE Act, it has increased to 275 patients after the first year to be able to manage by one medical provider. So they're really expanding the access to medically assisted treatment for pregnant moms. And also not just pregnant moms, but anybody suffering from an opioid use disorder to be able to get treatment at their primary care setting.
Thank you. The next question is, what would your recommendations be to help combat the opioid epidemic so that we can move from punitive to a more holistic approach?
I love that question. Thank you very much for asking that question. That's the question that I ask myself on a daily basis in my medical practice as well as on the HOPE committee. So again, attention and awareness. So definitely need to have some community engagement and awareness around realizing and understanding that substance use disorders are a medical condition that require treatment similar to diabetes, like I said before. So we need not only from top down, from tribal leadership and our health departments, but also for all of our community to understand and accept that substance use disorders require medically assisted treatment, mental health counseling, social services, identity, reconnecting with family and identity. And for prevention, to understand what the unique mental health needs are in the community as a whole, as well as with each individual family unit and individual within the family. Again, this is going to be my opinion, not necessarily reflective in any of the guidelines or policy, but from my clinical practice, I would have to say that the number one way to prevent substance use disorder is to ensure that we are normalizing mental health hygiene and getting individuals into the proper counseling and therapy for healing before they seek out drugs and alcohol as their way to escape and avoid some very uncomfortable mental, physical, or emotional feeling.
Great, thank you very much. I think we only have one more question. The question is, alcohol use often comes right along with use of other drugs, and it has longer range problems in the baby growing child. Can you talk about that too?
Absolutely. And especially even, I'm going to take off my Indian Health Service HOPE hat for the moment and just speak as Ted, the clinician from Ho-Chunk Nation. We address this in our medical staff pretty much on a monthly basis, and we're looking at our own internal statistics through looking at diagnosis codes, and we by far see that alcohol use disorder causes there's a higher incidence of it, and it causes statistically a lot more death than opioids. Opioids get a lot of recognition because there's an immediate consequence, especially with how potent our heroin has become, with it being laced with fentanyl and carfentanil. So unfortunately, alcohol use disorders been kind of normalized over the past couple of decades and doesn't get as much as attention, but there are definitely long-term negative consequences, including death from, cirrhosis of the liver and organ failure. So we definitely, when we're talking about neonatal abstinence syndrome and opioid disorder, we need to make sure that we're including alcohol use disorder right along there and ensuring we're protecting our communities from that. Because I still do have patients that are exclusively alcohol use disorder or exclusively opioid use disorder. I only have a very small handful of patients that they're getting Vivitrol because they're struggling with both. Either way, the root cause tends to be the same, where they've at some point in their lives experienced some kind of great loss or great trauma, and since that time, they've been self-treating with a chemical that has only caused more problems for them and their families.
All right, thank you. Well, we are getting close to the end of the hour, so I'd first like to thank our speaker, Captain Ted Hall, for this very informative presentation and your willingness to join us today. And we'd like to thank everyone who joined us today. Please don't forget to complete the feedback form that you will receive in the follow-up email after this webinar. And this webinar will be available as a recording soon on our YouTube channel that you can access from our website. Feel free to send the link to the webinar recording to any of your colleagues who may be interested. So now we just have two more announcements before we leave. Mark your calendars for our NCAI Policy Research Center monthly webinar series. It's usually the fourth Thursday of the month. This month was different. And please watch for announcements for the next topic on our website, on our Twitter feed, or on our listserv. If you are not on our listserv, email research@ncai.org and we can add you. We've also included our Twitter handle and website information on this slide. And please save the date. Join us for our NCAI 75th Annual Convention and Marketplace in Denver, Colorado on October 21st to 26th, 2018. We hope to see you all there. You can find the registration information for the NCAI Annual Conference and the agenda, which will be available on the NCAI website, www.ncai.org. Again, thank you so much for joining us today. This was a really important and informative webinar. I'm really grateful to our speaker, and thanks to everybody who had questions. And we hope that you have a really great rest of the day. Goodbye.